Okay, and our next speaker is DeAnna Minus-Vincent, who is the Senior Vice President for Chief of Social Integration and Health Equity Strategist from the RWJ Health. DeAnna, we're delighted to have you. Oliver, you can have her slides put up. Great, thank you.
Thank you so much for having me. I really appreciate it. Okay, so I'm going to be talking about social determinants of health and two of our programs, primarily Health Beyond the Hospital. And we are really just getting started in this space and learning a lot, as well as talking about our ending racism journey. Okay, so Health Beyond the Hospital is just starting. It's primarily starting in our hospitals, and then we're going to be moving into our physician settings. So what it is where we are screening our patients for their social factors in the clinical settings. We want to make it just as routine as height and weight. And while we're doing that, we're trying to overcome the known barriers for patients while creating efficiencies for providers. We know that providers, they weren't asking these questions because they weren't getting reimbursed. They didn't know the resources that were out there. They didn't know how to broach the subjects, and they didn't know where to document, and resources were continually changing. And as far as patients, they had all the issues that we knew about. It was cumbersome to navigate the healthcare system. It was more cumbersome to navigate the social service sector. The sectors did not speak, pride and stigma and all of those things. So we tried to both understand best practices from healthcare providers across the nation, but also learn from other sectors. So I want to play a portion of a short animation that we developed. And let me just optimize this video clip. And in the interest of time, I am going to fast forward a little bit.
I'm DeAnna Minus-Vincent, Corporate Vice President, Social Determinants of Health. I am here.
Engaged patients. Let's take Marcus. Marcus is almost 50 years old. He's done well for himself and his daughter, Savannah. He's a union bus driver and a single dad.
This is Greta. She's originally from Germany. Greta moved to the United States when she was in her 20s. Although she has been here for 40 years, English is still a struggle. She has cancer, but it's currently in remission.
Finally, Dee. Dee is a busy healthcare nonprofit executive who just completed her master's degree. Better still, she and her husband just found out that they are pregnant with their first baby.
First, let's talk about how things got difficult and really bad for Greta. For her, not only did she sometimes have trouble communicating in English, Social Security was her only income. It was less than $6,000 a year and had to cover all of her expenses. She had fallen behind quickly and didn't see any relief in sight. Luckily, Greta had received her cancer care at RWJ Barnabas and was already in the system when she got a call from someone named Eva who wanted to talk. RWJ Barnabas's relationship with government partners made it easy for Eva to get Greta enrolled in SNAP for food support and heat assistance, which eased her budget. She was also referred to a local community center for free group exercise classes, where she found an antidote to the loneliness she'd been experiencing since cancer treatment. She also signed up to have a community health worker visit her once a month to help with other issues. And, as is often the case, she shared her newfound knowledge about her community's resources to help her family and friends.
Dee loved her job. She was passionate about using data to develop programs to make mothers and babies healthier. She didn't mind the long hours or the challenging tasks. In fact, she grew up knowing that she had to prepare more and study longer if she wanted to be successful. That's just the way things are. She did mind the subtle undertones and covert or sometimes overt actions that came with the job. Dee knew something wasn't right. She'd been cramping and spotting all day, and she called her doctor, who told her this sometimes happened to women who were pregnant for the first time, and she shouldn't worry unless it continued to happen. Dee's first baby joined the disproportionate number of Black infants that die every year, despite a mother's income, education, or health. That is now being attributed to the body's reaction to constant stress. Luckily, Dee found her way to RWJ-Barnabas Health. In addition to her medical history, Dee's new OBGYN sent questions to her cell phone about her nutrition, housing, substance use, and daily activities when she made an appointment. Dee knew she needed to find ways to make self-care a habit and find ways to deal with stress at work, and her new doctor had the right information to offer the right support. It's been a year since the talk. Dee has monthly calls with her coach to make sure she's taking care of herself. She gets a weekly email with new heart-healthy recipes to try with her husband. She does yoga twice a week, and conversations with a counselor have helped to deal with the stress and microaggressions at work.
Marcus was always a big kid, and he became an overweight adult. His chart probably labeled him as morbidly obese. He'd made peace with the fact that obesity and early death were in the family genes. Savannah was heading down the same path. In his mind, this was okay. In his culture, almost everyone he knew was thick or big boned. But he noticed Savannah was now bigger than the girls in her class. And for him, some tasks were getting increasingly harder for him to do. Luckily, his path took him to RWJ-Barnabas. Marcus got a similar talk to Dee on the day he walked into the ER with chest pains and flu-like symptoms, but it wasn't a lecture. Marcus took an ACEs screening and realized that talking to a counselor might help. He was referred to a licensed therapist who took his insurance and who could do telehealth appointments that worked around Marcus's work schedule. He joined a weight loss and support program, getting weekly text messages with encouragement and useful tips. He also got the schedule for the RWJ-Barnabas Health and Wellness on Wheels mobile unit that visits his neighborhood to teach him about healthy recipes. He also received the address to a local food hub, which works with urban farmers to sell locally grown produce. Marcus and Savannah have both changed their lifestyles. Savannah has even started participating in cooking classes at one of the food hubs and is scheduled to join the summer camp and learn about.
So I wanted to share that just to give you a flavor of the program. And you may say, of course, that's what we do. We provide patient-centered care. But that isn't the norm. And the differentiators is that we built this program with equity at the core. And some of our colleagues across the nation don't provide universal screening. And that was very important to us because Dee was me. I was working in maternal child health. I was sitting on the governor's first blue ribbon panel on Black infant mortality. I was talking to women about their fetal losses, and I lost my first baby, and I had everything was available to me. And that's why part of the reason that it was so important to me that we did universal screening, because when I first went into the emergency department, one of the first things the nurses said to me was, "So, hun, do you have any clean veins?" And all of my veins are clean. And I knew that growing up as a Black woman in Trenton, New Jersey, that race is a problem, racism is a problem, and that if we were going to do this, we were going to try to do as much as we could to take those sorts of things out. And we knew that if we did not provide a universal screen, that we would be forcing our clinicians to decide who to ask and who not to ask. And we did not want to put them in that position, nor did we want to place stigma on those people who were asked and those who weren't. And we knew that everyone has social determinants, so we were going to ask everyone. We also wanted to culturally adapt the messaging. So we engaged with a third-party vendor who sequenced the questions appropriately, who used behavioral economics to outreach using every segmenting strategy that Nordstrom or Target or all of the everything that other marketing sectors use. So really encouraging the health and social sector to use what big business uses. If Target knows where to put the toy when my child cries, then we really need to use those same strategies. We wanted to really look at patient-centered support as far as modality and intensity. I think a lot of times, you know, my career has been spent in the government and nonprofit and healthcare sector. And I think a lot of times for the low income population, we say, give them a outreach worker or give them a nurse home visitor. Well, I might, if I'm low income, I might have 2 jobs and only have 3 hours to spend with my child. And I might not want someone coming into my house. I might have a prenatal outreach worker and a housing outreach worker and a food service outreach worker. And I just do not want one more person coming to my house. And just because I'm low income, I can probably text and use virtual environments, because while we may want to believe that people don't have smartphones, that's not what the data bears out. The data bears out that urban individuals of color have smartphones. And so really looking at what modality and intensity looks like to really provide people with the services that they need, when they need them, and how they want to be served in the language that they want for them, but then also to look at cost savings. If we, as we move to value-based care, if we can help someone for $10 as opposed to $600, let's see what that looks like. We also wanted to think about thoughtful integration into existing processes. So really incorporating the SDOH screen into the electronic health record to think about efficiencies again for our providers, but then also to track outcomes and think about predictive analytics for our patients. And then ultimately, which for a data nerd like myself, to think about prescriptive analytics so we can create healthier communities in the long run. To think about seamless and streamlined connection to services with feedback loops to our providers, because I'm sure as clinicians, all of you know, you might give someone a prescription and they never get it filled. Prescription's only as good as if you get the medication. And we know that that becomes non-compliance and non-adherence. So really understanding if in fact we prescribe someone to go to the food bank, we want to make sure that they get there. So what does that loop look like? How do we make sure that that 360 loop happens? Additionally, working with our state government partners. Immediately prior to my time at RWJBH, I worked with what is now a national nonprofit to use big data to help low-income people access public benefits via phone, mail, and other virtual mechanisms. So how do we, if someone's on Medicaid, they're highly likely eligible for other public benefits. So how do we take someone who's on Medicaid, indicates that they're hungry and not on SNAP or food stamps, and streamline that process so that they don't have to complete the whole form again. So we're working with our partners in state government to ensure that they get the benefit without them having to go through all of the paperwork, and working to make those policy options happen, as well as with heat and other things, especially in this COVID environment when people may not have ever accessed government benefits. Building up the capacity of our community-based providers. We can't, as a large, second largest employer in the state, automatically start sending 1,000 people to a small food bank without remunerating them appropriately. And then ultimately, as we start to see savings, how do we share those savings with them? Conscious efforts to quantify outcomes and savings when social determinants are addressed. So really thinking about maximizing utilization, quantifying ICD-10 codes and CPT codes where we could already get reimbursed for substance use and things like that. And then really socializing SDOH with patients. We can't automatically start asking them about, can you afford food without them feeling some sort of way. So really making sure they understand why. Even things like race and ethnicity, a lot of times they don't want to answer, but we really need to make them understand why we're asking these questions. And then continually reflecting and refining and understanding that it's okay to change. It's okay to change the process. These are just some screenshots of the SDOH screen in our EHR. These are the areas that we ask about. So both food security and nutrition. So not only can you afford food, but are you eating healthy foods? And again, that's because it's a universal screen. Housing security, not affordable housing, because New Jersey has a shortage. We would never get there. We were also really careful, and I think you see it on the next screen, in building out language preference and making that a static field, so that we understand that I only speak German. You can't give me written English instruction if you expect me to be compliant with my healthcare. Social determinants are there so every provider can see that I can't afford food. There's a social determinants of health wheel, so it's right there kind of for everyone to see. So what have we learned? We are currently in several pilot sites. We are in a few emergency departments, children's specialized. We wanted to look in different clinical settings so we could build out the processes. So once we go system-wide, we are in OBGYN, we are in inpatient facilities, and we've learned that it's okay to change. We've changed some tech providers. We understand that, as I should have known since I've sat on the other side at a tech provider, that everyone will tell you that they can integrate. Not really true. So it's okay to change when things don't work. We are at a 45% contact rate and a 18% completion rate, which is great considering that Verizon and Comcast have a 1 to 3% response rate. So we are pleased with that. We can always do better. Future state, what questions do we seek to answer? We're about to go into primary care practices once Epic is fully rolled out. Continue to work internally and externally to streamline processes and continue to socialize it with providers. Because New Jersey is so diverse, we still have some people who believe that higher wealth individuals don't have social determinants, and we all know that that's not true. Leverage community entities to use technology platform to screen individuals. Also, really work with trusted resources. We know that not everyone is connected to even healthcare. So how do we leverage faith-based organizations? How do we leverage a school nurse once children are back in school so that they are screening and referring people to community resources and to their PCP so that we can create healthier communities, which indeed is RWJBH's mission. And then really focus on key questions. Do low-touch modalities result in the same health outcomes as high-touch modalities? What is the cost differential when using low-touch versus high-touch, if indeed they result in the same health outcomes? And what is the PMPM? And then really taking a step back, and while we know that 80% of all health outcomes are due to socioeconomic and behavioral and environmental factors, looking at that conscious and unconscious bias with a different lens and understanding that race and racism play a huge role in, I mean, we've all seen the body and 40% of socioeconomic factors, but putting a different spin and looking at the core factors. So, and addressing the policy implications and blighted neighborhoods and the school funding formulas and food deserts and food swamps, looking at access issues, looking at policies such as, is our technology right, to ensure that we are addressing, that we are providing the same services to people with darker skin as our pulse oximeter machines are providing the same services, and things such as that. And that's where we've been working to end racism across the system, where we have 4 key goals for our patients, our workforce, our communities, and our operations, so that we are providing a holistic view of addressing the social determinants of health. And I will stop there and see if there are any questions. I know that was quick. I was trying to stick to my time frame.
Thank you, DeAnna. If you can minimize your screen so we can get back to the group, that would be great. At the end, I just want to say, you know, we've never met in person, but anybody who can use Prezi and can put Targaryen, the mother of dragon, to their slides, you had me a hello. For those of you Game of Thrones fans, questions.
Amen to that.
Yes. You know, that was great. As people are thinking about questions, I think that really centers us to sort of where we began today in terms of the Institute's commitment towards health equity, to some of our speakers talking about the future opportunities, to the state of New Jersey, to our collaboration with Barnabas Health, to your talk. I think there's so much alignment that I'm hearing today through various speakers. And I think through our discussion in our executive team meeting, as well as our group meeting, I think the issues of health equity consistently and rightfully permeates through all of our discussion points, as not only our framework, our vision, our metrics, our measurement for our success and failures will be very much tied to that. So let me see if other group members may have questions. All right, and I don't know if you have other questions as well for DeAnna.
Yeah. Hi, DeAnna. Thank you so much for that very powerful narrative. And so I am interested in hearing about your vision for expanding, collecting social determinants of health data, and the importance of, I think, what you were hinting at disaggregating data. You can speak more to that.
Yeah, I think when I first came to the system, I thought I was going to work further upstream, because my goal is really to think about the prescriptive analytics and how do we think about at what point do we ping an infant Black girl to understand how she doesn't become an obese Black woman that draws on the system, because I was also 120 pounds heavier at some point in my life, and I cost Horizon Blue Cross, sorry, Stephen, a whole bunch of money. And you know, I was asthmatic. My mother has heart disease. My father has diabetes, and both of my grandparents died the same. And none of my doctors ever said you should probably lose weight. And once I had a child, and my husband, who I like still a lot after 26 years, I said, you know, forever isn't today, and I should probably lose this weight. And I didn't understand the correlation between stress, lack of sleep, and I worked in state government, and literally when I left, 50 pounds fell off my frame. And I mean, I had to work for the other 70. And I think really understanding, once we have this collection of data, of course, it's great for the individual, but is it that we need every child? And some of it we know, like, okay, they need early childhood education and extra, but when do we ping them, and how do we ping them so that we can have healthier outcomes, and what is the right prescription per child. Of course, I think everyone's individual, but how do we get there so that we don't see the same outcomes, and what do we need to provide, and what policies do we need to change? And I know that sounds so Pollyanna, but yeah. So
No, thank you.
where I'm
That's really
hoping we can
important.
get.
Okay, if there's last call for questions for DeAnna.